Hello everybody, Pintong here from the Center Affiliated Hospital of Zhejiang University School of Medicine. I am Professor and Director of Department of Ultrasound in Medicine. Today, my topic is updates on CEUS for thyroid nodules and cervical lymph node. This is off-label applications of CEUS. Firstly, I would like to introduce my cities to you. From this map, we can find Hangzhou is very close to Shanghai. It was said by Marco Polo, a famous Italian traveler in the 13th century. Hangzhou is the city of heaven. It's without a doubt the most splendid and finest city in the world. And the 19th Asia Games will be held in this city. Warm welcome everyone to visit our city. I want to thank my colleagues for their great contribution to this work. The objectives of these presentations, including background CEUS for characterization of thyroid nodules, CEUS for cervical lymph node, CEUS for assessment of thermal ablation. Now to the background. Differentiated thyroid cancer, which includes papillary and follicular cancer, comprises the vast majority of all thyroid cancers. 25% of the new thyroid cancers diagnosed in 1988 to 1989 were less than 1 centimeters, compared with 39% of the new thyroid cancer diagnosis in 2008 and to 2009, and compared with over 60% of new PTC diagnosis recently in China. This tumor shift may be due to the increasing use of neck ultrasound examination or other image and earlier diagnosis and treatment. Based on the ultrasound findings, the thyroid nodules can be classified into high suspicion, middle suspicion, low suspicion, and very low suspicion malignant nodules and benign nodules. The high suspicion thyroid nodules were defined as a solid hypoechoic nodule or a solid hypoechoic component in a partially cystic nodules with one or more of the following features, which is irregular margins, microcalcifications, taller than wide shape, disrupted ring calcifications with small extrusive, hypoechoic soft tissue component, or evidence of extracellular extensions. Now let's look at these figures. This is a microcalcification. The diameter is less than 1 millimeters, and this is an irregular margin and extremely hypoechogenicity compared to the strap muscles and taller than wide shape. As for high suspicious thyroid nodules, the malignancy risk of those kind nodules ranged from 70 to 90%. There are still 10 to 30% of those nodules are benign. Now let's look at this image. The nodules over here we can find is a hypoechogenicity, taller than wide shape. The texture of these nodules is very hard. However, these nodules was evolved from the thyroid cyst. Now let's look at another case. The thyroid nodule here with microcalcifications and hypoechogenicity and hard textures, and also these nodules was evolved from the thyroid cyst. So how to distinguish benign from those kind of nodules? Here I wanted to introduce the technique or the CEUS for thyroid nodules. This is benign thyroid nodules uh, with isoechogenicity and regular margins, which had already confirmed by fine needle aspiration cytologists. Now let's look at this movie. These benign nodules present with a well-defined margin and hyper-enhancement patterns on CEUS. Now let's look at another case. These nodules present with hypoechogenicity, taller than wide shape, and microcalcifications, which is high suspicious uh, malignant thyroid nodules on B mode. However, now let's look at CUS. We can find that these nodules have no enhancement and with a well-defined margin. This is benign nodules too. Now let's look at another case. Hypoechoic nodules, well-defined margin and no enhancement on CUS, and which also have confirmed by the fine needle aspiration. This also is a benign nodules. Also is evolved from the cyst. And here I would like to show another cases and the hypoechoic nodules with hard textures on elastography. Now let's look at the CUS. These nodules present with a well-defined margin and no enhancement on CEUS. So this also is a hemorrhagic necrotic colloid nodules. This is benign nodules. Now let's look at another case. The hypoechoic nodules, and the texture is very hard on the elastography, and the CEUS shows no enhancement, well defined margin, and this nodule also is benign. Now let's look at another case. Hypoechoic nodules with hard textures, which also have already confirmed by fine needle aspiration. However, these nodules is a hypoenhancement in the early arch phase rather than no enhancement. So this is malignant nodules on CUS. Now let's look at it again. Hypoenhancement in the early arch phase. Now let's look at this movie. I saw in echogenicity nodules with halos, and the texture of these nodules is very hard. So what kind of these nodules will be? Now let's look at CEUS. This nodule present with a hypo-enhancement in the early arch phase. Based on the CEUS findings, it's a suspicion of malignancy, and which have already confirmed by the fine needle aspiration cytology. And here I would like to show two cases to you with the same ultrasound findings on B mode. However, it's difficult to distinguish the benign from malignant based on the 2D findings. Which one is benign and which one is malignant? Now let's look at CEUS. We can find the case when this nodules is a hypoenhancement on CEUS in the early arch phase, and so this is malignant nodules. Well, how about the case 2? Case 2 nodules have no enhancement and with a well-defined margin. Of course, this is a benign thyroid nodule. So, hypoenhancement pattern was more common in the malignant nodule than in benign nodule, while hyperenhancement pattern was more common in the benign nodules rather than malignancies. And the no enhancement pattern strongly indicate benign nodules. The sensitivity and the specificity of hypoenhancement for diagnosing malignant thyroid nodule was 74.6% and 61.5%. Now to the CEUS for cervical lymph node. Based on this diagram, the position of the cervical lymph node can be classified into 7 levels. The ultrasound features of malignant lymph node included microcalcification, cystic aspect, peripheral vascularity, hyperechogenicidity, and round shape. The sensitivity and the specificities of each sign were listed in this table. Now let's look at this lymph node. This is an oval shape and lymph node, and the color Doppler shows there have some vessels within this lymph node. And now let's look at the CEUS. We can find the contrast agent perfused from the hilar to the center of this lymph node and spread out with centrifugal patterns. This is a reactive lymph node. It's a benign lymph node. Well, how about the malignant lymph node? This lymph node we can find present with heteroechogenicity. This is a hyperechogenicity here, this range, and we can find this is hypervascularities in these regions. And well, how about the CEUS? We can find that the hyperenhancement in this region can be detected on CEUS. This is a malignant lymph node. They have three lymph nodes were detected by ultrasound with a round shape and macro calcifications, and the CEUS shows centripetal enhancement in the atrial phase. Now let's look at it again. This is a centripetal enhancement on CEUS. This is a malignant lymph node. And this is another lymph node with hyperallergenicity and peripheral vascularities, and the texture is hard. Well, how about the CUS? This lymph node present with a hyperenhancement in the atrial phase. Here I have two lymph nodes. We can find this lymph node and another lymph node, and it's difficult to make the diagnosis which one is benign or which one is malignant, or both of them is a malignancy. So now let's look at the CUS. We can find hyper enhancement, and this is hypo enhancement. So based on these TIC curves, we can find this one is a hyper enhancement with a high intensity compared to this one, and this is a malignant lymph node. This is a benign lymph node. This lymph node looks like a peanut, and also the vessels can be detected using color Doppler flow image, and the CUS indicate the hyper enhancement on CUS, and this also is a malignant lymph node. So the characteristics on the CUS is that the more common of the central petals patterns will be found on the metastatic lymph node, while the centrifugal patterns will be more common in the benign lymph node. And also, the hyperenhancement pattern is more common on the metastatic lymph node. And also, we're planned with a heterogeneous enhancement in the metastatic lymph node. These tables show the sensitivity and the specificities of each characteristics on the CUS, including the known or hyperenhancement, heterogeneous enhancement, and the perfusion defect, and the ring enhancing margins. Now to the assessment of thermal ablation. Ultrasound-guided thermal ablation is widely used to treat not only for HCC but also for PTMC and cervical lymph node metastasis. Now let's look at this case. This is a thyroid nodule with hypoallergenicity, and the texture is very hard on the elastography. Well, CEUS indicate the hypo-enhancement in the early artery phase, and the TIC curves also showed that this nodules is a hypo-enhancement in the early artery phase in this red line, and the fine needle aspiration was performed to confirm that this thyroid nodule is a PTMC. After the PTMC fine needle aspiration, the radio frequency ablation was performed, and the CEUS was performed out the thermal ablation. We can find that the ablation zone were clearly observed on the CEUS, and this is 6 months out the radio frequency ablation, and the 6 months out the thermal ablation, we can find the ablation zone is a short shrink. Now here I have another case. It's a hypocogenicity thyroid nodule with hard textures. Fine needle aspiration were performed, and the PTMC were confirmed by this fine needle aspiration cytology. And the CEUS were performed before the ablation. This nodules is a hypoenhancement patterns on the CEUS. This is a radiofrequency electrode were implanted into this thyroid nodules. And we can find the weapons was seen within these nodules. After the radiofrequency ablations, the CEUS were performed, and to assess the efficacy of ablation effect. And 1 year out the follow-up, the ablation zone will disappeared. Here I would like to show more cases on the radio frequency ablation for those kind nodules. These nodules plant with a hypoallergenicity taller than wide shape, and also the texture is very hard on elastography. CEUS shows hypoenhancement patterns. Fine needle aspiration were also performed before the ablation, and the PTMC were confirmed by the cytologist. The procedure of the radiofrequency ablation showed here. We can find this is a radiofrequency electrodes were inserted into the thyroid nodules. From the ablations were from the distal to proximal, from the bottom to the top, and the weapon was seen within this ablation room, and we can change the radio frequency electrode with a multi-point ablation. And after the ablation, the CEUS was performed to assess the effect of this ablation. And this is before ablation. We can find the nodules here. After ablation, this area have no enhanced, which can be compared to each other, the before ablation, post ablation. The case 4 we can find is a PTMC on B mode with hypocogenicity and hard textures and the hypo enhancement in the early artery phase. Final aspiration was also performed prior to the ablation, and these nodules were plugged by the final aspiration cytology. Also, the radiofrequency electrodes were inserted into these thyroid nodules, and we can find the tip of these electrodes, and the vapors was seen and covered the whole thyroid nodules, and the echogenicity was changed after the ablation. CEUS were performed after the radiofrequency ablation to assess the effect of this ablation, and 6 months after ablation, the CEUS were performed again to assess the efficacy of this ablation. We can find the ablation room is shrink. Here have case 5 is hypocogenicity nodules with a hard texture. CEUS shows hypo-enhancement patterns in the early artery phase, and the TIC curves also indicate these nodules is a hypo-enhancement. Final aspiration were performed, and to confirm that this nodule is a PTMC, and the procedure of this ablation showed that the hydrodissection was performed to separate the common carotid arteries and the ledgers to avoid the damage during the ablation. We can find that this is a hydrodissection were prepared, established. This is a carotid arteries. This is a PTMC. After this hydrodissection establishment, the radiofrequency ablation will be followed. And also we can find that the weapons were seen within this area, and after the radiofrequency ablation, the CEUS were performed again, and to assess the ablation room. The size of this ablation room can be detected using CEUS to assess the effect of ablation to confirm where the safe margin of this ablation. And out the ablation, the echogenicity of this ablation zone have changed. and follow up, we can find this is ablation room. There are no enhancement on CEUS, and out 6 months and followed up, the ablation room is shrink and on longitudinal view, and this is a transverse view, and the 6 months after ablation, we can find that the ablation room is shrink. And here I have another case. This thyroid nodules located on the isthmus with a hypoechogenicity, and CEUS indicate this thyroid nodules is a hypoenhancement, and also these nodules were confirmed by the final aspiration, and this is a thyroid nodule here. So before the ablation, we can find the hydrodissection was established to separate the muscles and the gland and the trachea and the gland. And this is a hydrodissection were established to separate the gland and the trachea. After the hydrodissection, followed with radiofrequency ablation, and CEUS were followed to assess the ablation room to assess the effect of ablation, and this area have no enhanced. So totally 157 patients underwent radiofrequency ablation, and 178 patients underwent surgery for low-risk PTMC were included in this study. And at last, following up, 39 PTMCs in the radiofrequency ablation group completely disappeared, and no local recurrency, lymph node metastasis, or distant metastases were detected in either group during the follow-up period. The ablation time and the time for hospitalization in radiofrequency ablation group were shorter than those in surgery group. The average hospitalization expense for the patients in radiofrequency ablation group was cheaper than those in surgery group. So moreover, the cosmetic score was found to be higher in radiofrequency ablation group than that in surgery group. And now let's move to the lymph node metastasis ablation. This is a lymph node. We can find the hyperenhancement on the CEUS can be detected, and fine needle aspiration were performed, and this lymph node were confirmed by the fine needle aspiration, and this is a metastasis lymph node. And followed on the laser ablation, we can find this is a laser fibers were inserted into this lymph node, and will start to ablation. We can find the weapons gradually spread out and cover the whole lymph node. This is a laser fiber and start to ablate this lymph node. After the laser ablation, CEUS were performed to assess the effect of ablation, and we can find this area have no enhanced, and 6 months we can find the lymph out ablation. The lymph node was smaller and there are no enhancement. Here I have another lymph node with hyperechogenicity and peripheral vascularities with hyper enhancement on CEUS. And this lymph node is close to the jugular vein, so the hydrodissection should be established to separate the establish to separate the jugular vein and the lymph node. So we can find this is a hydrodissection have already established to separate the jugular vein and the lymph node, and followed with a laser ablation. We can find this is a laser fibers were inserted into this lymph node and start to ablate. This is laser fibers, and this is a target lymph node. This is a jugular vein. And after the laser ablation, the lymph node have changed on the echogenicity, and there are no enhancement on CEUS. And here I want to show another case. This lymph node is a hyperechogenicity and with hypervascularities and the hyperenhancement on the CEUS. And the fine needle aspiration were also performed prior to the laser ablation. And we can find lymph node here, and the laser fiber have already inserted into this lymph node and will start to ablate. And also we can find the weapon was seen within this lymph node and will cover the whole lymph node. And 6 months post laser ablation, we can find that the echogenicity of this lymph node has changed to the hyperechogenicity, and this is a start to ablate. And we can find the weapons can be seen in this lymph node. And here I also want to introduce another lymph node. This lymph node with a hypoechogenicity close to the common carotid arteries, and fine needle aspiration were also performed, and the pathology examination was showed that this is a malignant lymph node, and this lymph node were planned with a hetero-hyper enhancement on the CEUS, and this is a common carotid arteries. Now let's look at this. Before the ablation, we can more care about some main structures, which one is vagus nerves over here. So the hydrodissection also should be established to separate the lymph node and the vagus nerves. And this is the procedure of the hydrodissection. And we can find the lymph node and the vagus nerves have already separated based on this technique. This is a vagus nerves and this is a lymph node. And the radio frequency ablation will be followed, and we can find this is a radio frequency electrode were implanted into this lymph node, and will start to ablate this malignant lymph node. After the ablation, the CEUS were performed to assess the effect of the therapy, and we can find this area have no enhancement. And then followed up 6 months after the ablation, we can find the size of lymph node has smaller, and there are no enhancement. And 1 year after the ablation, this lymph node have no enhanced. There are no enhancement within this lymph node. So interestingly, I wanted to show you the last case. This is a metastatic lymph node located on the subclavian, and this is a subclavian arteries. And before the therapy, we can find the lymph node were planted with a hyper enhancement on CEUS, and this lymph node is hypogenicity, and the microwave ablation were performed on this lymph node, and this is a microwave needle track, and after the ablation, we can find this lymph node have no enhanced. And 1 year after the microwave ablation, this metastatic lymph node also is from the PTC. There are no enhancement, and the size of this ablation zone is shrunk. And 2 years after the microwave ablation, we can find the ablation zone is shrink very much. So the summary is CEUS can be used to distinguish benign from malignant thyroid nodule with high sensitivity and specificity. Also, CEUS can be used to differentiate benign from malignant cervical lymph nodes. And CEUS can be used to assess the effect of thermoablation of PTMC and cervical lymph node metastasis. And furthermore, ultrasound-guided thermoablation may be an effective and safe method for treating low-risk PTMC with simpler advantages of a shorter operation time and hospital stay compared with surgery. And here I have a recruitment. We have an international clinical multi-center trial, and this trial is a radiofrequency ablation versus conventional surgery as treatment of papillary cellular microcarcinoma. So one welcome everyone to join this clinical trial. Thank you very much for your attention.